for your post call. No problem. All right. So what we've done quite a bit on face and mandible and things like that. So today's was actually just meant to be a little easy one. When I say easy, we're just going to look at some fun stuff that you don't normally get a chance to look at, all right? But if you guys want to see, the rest of it, then you go back to the older videos and things like that. So we've got that, right? So there's two other videos. There's the first one from earlier in the year. It's just, I posted it a little while ago. So it covers more of the theory of the face and, how the face works and what the physics of the face and the zygoma and things like that, and the mandible. And then the one we did 2 weeks ago was just about the different types of fractures, and we were trying to pick out fractures from everywhere, right? So today we're just going to look at some other stuff, right? So this is a normal mandible, okay? So what normally happens is that, I'm not really too worried about that. What I actually wanted you guys to have a look at was the condylar process, all right, and the coronoid process, and actually put that into view on an X-ray. Because actually in taking a little survey of the doctors, a lot of people forget about the coronoid process that's here. A lot of people feel it's the TMJ and that's it. And they forget about the coronoid process also being attached to the face, and that you also got to look at it. And in fact, when dislocations happen, which is what we're going to concentrate on today, it's very possible to dislocate both the TMJ and the coronoid. Okay, just to point it out, okay, not to say it's what you call extremely vital, but just to understand the physics and the anatomy that goes along with that, all right? So basically what happens when you have any sort of mandibular dislocation, generally it's this area here that will come out, all right? The mandibular conda will come out from there, and then you normally must have some effacement of this as well. So there's also the possibility of fractures, although it doesn't always happen, but it's just something to keep at the back of your mind, okay? All right, so let's have a look at that. So what do you think is a problem here? Now, if we compare it to the last one. Oh, sorry, I'm thinking it's showing. So I'm wondering why you're looking at me. Apologies. Okay. There we go. All right, sorry about that. All right, so let me just show you guys again. All right, so that like I was saying, so this is what we're basically talking about. All right, so we're talking about the mandibular conda and the coronoid process. All right, so you can see how both are linked to the joint of the jaw to the skull, all right, or to the face itself. Okay, but just remember that this is the normal look of it. So you have the jaw that follows along here, and basically it should slot into your temple with the TMJ like that, and then your coronoid just fits in underneath there, okay, just under the zygoma on that side, okay. So we just wanted to have a look at the normal thing of how it looks, and then let's have a look at an X-ray. All right. So can you guys see what's the problem? This is not a difficult one. Actually, this week I'm not trying to catch anybody out, do anything hectic. It's just actually a bit of a fun presentation, just to try and get an idea of how certain things are done. All right. So this patient presented with an inability to close the mouth after a big yawn, and this is the X-ray that you get. So what's the problem? Even if you didn't see the X-ray, should be, okay? Dislocation, very good, dislocation of the jaw, all right. Now, the thing is, why I like this one is it's, oh, my bad. This is actually quite an obvious one, right? But let's just take a look at it from the previous slide as well. So, like we said, the mandibular condyle, or the condylar process is supposed to be here, okay? So that's the easiest one to see, and then we have the coronoid process that sits over there, okay? So, when you're looking for a dislocation, let's follow that thing again, right? Can you see it there now? All right, so it's nowhere near where it's supposed to be, okay? And then if you follow this on this side as well, you'll notice even your coronoid, although it's a bit difficult to see here, but you can actually see your coronoids popped out of place as well. Okay, the reason why I mentioned this is some people find it a bit difficult to actually note whether there is a dislocation or not when it's not as obvious as this. All right. So there's two areas that you can look at. You can look at this mandibular process, and you can look at the coronoid, especially in minor, let's say slight subluxations and things like that, to actually try and figure out, is this really a dislocation or is it not a dislocation? But the majority of the time you can go from it clinically. Okay. Don't stress. Today is not a hectic one. We're actually just having a bit of a light one. We're looking at some odd things that we don't normally see on X-rays. All right. So what are you going to do with this patient? Solid uppercut. Get it back in place. Now you've got to relocate the jaw. So how do you relocate the jaw? Yeah, very good. Yeah, give energy. Yeah. 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 No, you're 100% right. Okay, so that's the one way to do it. So this is just the labeled one, right? So this is where everything's supposed to be sitting, and that's where it's supposed to slot in, and that's where it is, all right? And on the other side as well, you can see that it's out, right? So it's a complete one. Oh, sorry. Just go back. Okay. All right, so that just gives you an idea of how bad the dislocation is, all right? So that's a bilateral dislocation on that side, okay? There you can see the coronoid there, and there's the other side of the mandibular process. Okay. So how do you reduce? So what we're going to discuss first is we're going to discuss the most common one that we all know. Let's have a look.
Temporomandibular joint dislocation. The head of the mandible is usually dislocated anteriorly from the mandibular fossa. And the standard reduction technique is to place your two thumbs on the patient's inferior molars and exert downward and backward pressure to replace the joint. What you need to do is get the head of the mandible down and past the anterior lip of the mandibular fossa. So you exert downward and backward pressure until you feel a pop. When you're doing this with a patient, I like to protect my thumbs with gauze because you're going to be exerting a lot of pressure onto the patient's teeth. So again, take your two thumbs and place them on the patient's inferior molars. And you might have to exert significant pressure as you pull the jaw down and posterior until you feel a pop. Another technique you might want to try is allowing the patient to bite down on a syringe between their molars. Then ask the patient to rock that syringe back and forth. This will allow them to use their own musculature to do the same downward and posterior force and relocate the jaw. Some patients may find it difficult to hold the syringe on just one side, so an alternate technique is to allow them to bite down on both sides and roll the syringe. And that's how you reduce a TMJ dislocation.
That guy really gave him something good, huh? He just looked at him, but it wasn't enough. So it's quite simple. A reduction is not difficult. What makes a reduction difficult is time. So the longer that the dislocation's been there, the more difficult it is to actually reduce it. So the fresher you get it, the quicker you do it, the quicker and easier it goes in. The longer you leave it, the harder it becomes. Okay. So for example, a patient who's come after 24 hours compared to somebody who's maybe had it for an hour or two, you'll feel the difference. And in fact, in quite a few, because there's such severe, buccinator spasm. I think it is buccinator spasm. You actually can't get that downward force going. So in those cases, the patients need theater, they need full relaxation, and that's when they pop it back in, all right? And then you get the other ones, the recurrent dislocators. So the recurrent dislocators, you pop it in, it pops back out. You pop it in, it pops back out. You pop it in, it pops back out. And there's a reason for that. Sometimes within that joint, there's actually ligament or tissue or cartilage that's actually now blocking the way. So that's why they keep on going in, going out, going in, going out. Those patients require maxillofacial. They actually need to go into the joint, clear out the joint, and then put the thing in, wire it in place. Don't worry, your MaxFac will do it. They'll fly out, like I say, in their private helicopter. They'll come out, do it, go back. It's well worth it for them, so don't worry. They'll definitely do that. There is a newer method that's been proposed, and it has worked quite well. Just want to put it on the video panel for those who are on Zoom. So the other method that's been proposed is actually not to do it from internal, but to do it externally, all right? Now, this one here, they found that it also works, but it's a bit of a learning process because it's not a well spread technique. It's being developed in a few hospitals at the moment. So essentially what happens is you hold the side that's okay. In other words, the side that's not dislocated. And you actually provide anterior pressure on that. Now, if you press yourself here, you'll feel it's quite painful, right? Because you've got your parotids and things like that. So you've got to have your patient nice and sedated. And then you grab the side that's dislocated, and essentially you provide counter traction. So in other words, by pushing forward, you're never going to dislocate this side. All that you're doing is providing pressure that way. And they found that it works. So what happens is with that one, actually, the jaw ends up going a bit laterally. And then it sort of slides back and then pops in. So that one there has also worked. And they found that it can actually work for bilateral dislocations as well, in that you've just got to steady the one side, pop that side in, steady the other side, pop that side in. But whichever one works for you, that's the thing. So it, just so that you know, you might start seeing it in videos and teachings and things like that over the next year or two, because they found it's got actually a good success rate, and it's far easier in terms of you don't get bitten. So that's why they're promoting that method as well. Okay, so here we have a wing bite X-ray. All right, so if you've ever worked near a dental clinic, you know what that is. All right, a wing bite X-ray. Basically, they're looking at all the teeth. So it's not the best X-ray, but what do you think that is? This little area over here that just doesn't look 100%. Even if you don't know the answer, what would you think it could be? It's a lesion, right? What type of lesion would you be worried about? Especially considering the patient's got no teeth and things like that. You can see the roots are open. Most likely be worried about an infection. Great. So I just wanted to show you guys what these infections of the jaws look like. Because sometimes if you are working in certain areas, you are the dentist, you are the doctor, you are everything, because there's nobody else available, right? So you have to know how to look at those X-rays. So these are odontogenic abscesses. Okay, so basically abscesses that come out from the root of the tooth. And there you can see one that's quite obvious. Here you can see another one that's quite obvious as well. And how do these patients normally present? They normally present to us with these huge swellings on the side of the face that we all want to suddenly send for ultrasounds and big CTs and rule out this lymphatic thing and that parotid thing. But the 99% of the time, it's just an odontogenic abscess, right? And in its worst form, it will lead to osteomyelitis of the mandible. Okay, so that's basically what you're seeing over there. It's like osteomyelitis of any bone, so not to worry. Okay, like I say, don't stress. Today is just a light topic. See, everybody's looking big frowns. How you're not going to see this very often, okay? Because we don't generally do wing bites in any sort of emergency department. The reason why I show it, like I say, if you end up in certain CHCs, certain primary healthcare clinics, you are the doctor, you are the dentist, you need to know how to, or even look at wing bite X-rays if they do them. Okay, so how do you treat this? You have to extract the tooth. Do any of you know how to extract a tooth? Don't ever apply to a PHC clinic, eh? All right, now it's quite easy once you get the hang of it. Huh? Removing teeth is it's absolutely something. Don't worry. I'm not going to teach you now because we don't have a dental dummy. But if you are interested, go and visit any dentist. They'll show you. It takes like 5 minutes to learn how to do it. You know? There's one ligament that you have to break. You just have to know where to grab the tooth, how to anesthetize, and you pull. And that's it. The tooth will come out. All right. So here we have another patient presenting to us with headaches, recurrent headaches over the last 2-3 months, mainly present over the right side. Of course, everybody LP'd this patient 10 times because headaches equal LP, right? But what's actually happening with this patient? Any idea? Especially if you look at the maxillary and the frontal sinus, what do you notice? So there's your maxillary sinus on each side. There's your frontal sinuses. What's the difference between the two? Very good, yeah. I think you can see it more on this one. What's that? Do we see straight lines in nature? We don't, isn't it? So that's an air fluid level, great. And if you look at this sinus compared to that sinus, you can see this one here is quite chock full of stuff. All right. So this is quite classic sinusitis, severe sinusitis. Okay. The reason why I mentioned this, we get a lot of patients being subjected to LP, CT scans, all these horrible, horrible things, MRIs too. you know, and being placed on triptans for migraines and things like that. Whereas the real problem is just sinusitis. So in reviewing a lot of, you know, files and things like that during audits, I came across this a few times where patients have actually been subjected to quite a bit. And yet, if you look at the X-ray, it's quite obvious sinusitis. Okay, so once the patient has sinusitis, it's easy to treat. Antihistamines, cortisone. If worse comes to worse, ENT for drainage procedures and things like that. And the headaches get sorted out. Now, if they still have headaches after you've drained their sinuses, then yeah, there could be something else, there's no doubt, right? But the main thing to look for is just this congestion and air fluid levels and things like that. And even before you send the patient to ENT will also ask for this because they also want to see more details. Is there any other way you can confirm the diagnosis? Yes, ultrasound is very good, right? But you need a high frequency ultrasound to be able to look into the sinus itself. But it can help you confirm the diagnosis. And then if worse comes to worse, a CT scan will confirm the diagnosis for you as well. But that should be ideally done by an ENT looking for something specific. It shouldn't be an accidental finding. It means that you wasted the patient's time. You know, if your report comes back as sinusitis as the cause of the headache, it means you've missed quite a bit. Clinically, you need to look at the patient's nose, you need to look at the conky, you need to look for inflammation, injection. They'll have a particular type of headache. It's an X type of headache. You know, it normally presents along the side, very congested, very full. They do have lacrimation sometimes. So if you can classify the headache, but there's a whole other lecture on headaches that you guys can watch at your own leisure. I'm not going to go through the whole thing again now, right? But when you suspect it, the view that is used is called Waters' view, right? But if you forget Waters' view, just put suspected sinusitis. The radiographer will know what view to take. Okay. Any idea what's going on here? So here we have a patient who's toxic, right? When we say toxic, I mean the child's got low BPs, has got high temperatures, is sick, not looking well at all, okay, and in severe pain, right? Has also been experiencing a purulent discharge from the ear. Any idea what's going on there? Very good, mastoiditis. Eh? So it's something we can't afford to miss. Okay. The reason why I say that, don't say that this is an abscess. It's mastoiditis. Okay. So it's just something that sometimes people have a bit of a problem with. Right? So it's hard to diagnose on X-ray. It's not really an X-ray diagnosis, even though this is an X-ray topic. But I just wanted to bring it up. I'm going to show the CT of what it looks like. Right. So it normally starts from otitis media and otitis interna, sometimes from otitis externa as well, with passage into the mastoid air cells. Okay. So once you get infection of those mastoid air cells, then of course this is what you see on the outside. Right? So very importantly, you get that back ear, right, where the ear starts getting pushed forward, very large, hard, but sometimes can be fluctuant as well, area behind the ear. Okay. So what does it look like on CT? Basically this, all right? So you get this, you know, let's have a look, all right? So A is the axial CT, all right? And B is the coronal CT, all right? Contrast enhanced, okay? Cortical breakthrough on the left mastoid, all right? With large abscess in the adjacent soft tissue. All right, so that's basically what they're looking at there. And then you're looking at a similar thing on this side, all right? Now, you must remember that CT is not your first point of call in the emergency department. It's a clinical diagnosis. But just so that you know, doing an X-ray is not going to help all that much. CT is the way that you need to go to be able to diagnose. And then how do you treat these patients? High dose antibiotics, referral to ENT. ENT needs to be quite aggressive with these patients to the point of surgery in some cases. All right, we've got to clean out that entire mastoid area. Okay. Ah, there we go. That was it. So I told you, short one today. Nothing too hectic. Any questions? Anything you want to know? Today was quite an easy topic. The reason being, next week we start with C-spines. Ah, that's going to be fun. All right. So I said I'll give you a break this week because next week you need to have thinking caps on because we need to start learning about C-spines and C-spine radiology. Right. On Friday, we're going to go through a bit of toxicology, but for now, we'll just leave it. If there's no questions from anybody, we'll end it there. And then the next one will be on Friday. Okay. All right.